Hello, my name is Bethan Jones, and I'm a PhD student at the University of the West of England in Bristol. Today, I'll be talking about patient activation and its relevance in rheumatology. Over the next 20 minutes or so, we're going to cover what patient activation is, what it looks like, and what it means to rheumatology patients, particularly around the growing interest in patient activation at the moment. Finally, we'll be talking about the clinical implications of patient activation and how we support people to actively manage their health in clinics. I am funded for my PhD by Versus Arthritis, but I have no other conflicts of interest to disclose, so let's get started. Let's start with what is patient activation. Patient activation describes the knowledge, the skills, and the confidence that you have to take an active role in managing your health, as well as how likely it is that you'll take steps to actively manage your health. If you have high levels of patient activation, you are a confident and skilled self-manager and you're said to be activated. If you are activated and you have high levels of patient activation, you're more likely to have greater confidence in controlling your condition and your self-management skills generally. You're more likely to have better health outcomes overall, often including physical health outcomes. You're more likely to have a positive perception of the care that you receive. And if you have high patient activation, you're also less likely to be depressed. You'll generally have fewer emergency admissions into hospital and spend fewer nights as an inpatient in hospital. And the evidence suggests that you'll also have lower healthcare costs overall. So it seems like the idea of understanding and harnessing patient activation feels like a bit of a win for everyone. I want to touch on the term patient activation because there is some debate about this. Because I know that it does suggest that perhaps the responsibility for activating people lies with healthcare professionals. I'm using the term today because not only will it help to link with the rest of the literature that I'm discussing, but also following qualitative research with my own rheumatology participants. They generally found the term acceptable, which is why I'm using it, but I wanted to mention some of the debates out there. Patient activation is a multifaceted concept and covers a range of skills, behaviours, abilities and beliefs under one umbrella. What we find is that it's closely associated with many other concepts, including health literacy, which involves being able to find, evaluate and use health-related information. Self-efficacy, the belief that you could take steps to manage certain aspects of your health. Health beliefs, which specifically here I refer to how severe you perceive your condition to be, and also some demographic factors, but the evidence around this is still quite mixed. And this point in the presentation brings us to our first poll question. This should appear on your screen so you can take part and click, and we'll be discussing the results of the poll at the end. So the first poll question is, have you come across patient activation as a term before? The responses are yes, no, and you don't know, for if you're not sure. I'll give you a few seconds while I discuss this to take part, and then we'll move on with the rest of the presentation. Now that you've done that, we'll talk about how we capture patient activation. Now, the most prominent way that we capture patient activation is using the patient activation measure, or the PAM. This was developed by Professor Judith Hibbard and her colleagues in Oregon in America in 2004, and was reduced down from a 26 to a 13-item measure in 2005. And this 13-item measure is its best known iteration. It was developed using qualitative research methods with participants with a range of health conditions, including some without any health conditions, and provides people with a score from 1 to 100, where the higher the score, the higher your patient activation. The PAM also provides people with a category once they've completed it, which is known as a PAM level. We'll be discussing these in more detail on the next slide, so we'll come back to this. The PAM was intended to be able to be used as not only a tailoring tool to help decide what self-management support to offer people, but also to evaluate the self-management support offered. It's been translated into well over 20 languages and used worldwide in a range of contexts, including both in and outpatient care. It was intended to be able to be used for both physical and mental health conditions, and both chronic and acute conditions. It is perhaps best known in physical health, but has been used in a range of conditions. Now, to discuss the PAM levels that I mentioned earlier that the PAM provides people with, I'll go through a brief description so that you can understand them in a little bit more detail. PAM level 1 is the lowest level and reports when people are perhaps unable or unwilling to take an active role in managing their health, and that they're largely led by healthcare professionals. At level 2, people have some awareness that they could take some responsibility for their self-management and are starting to take small steps to do this, but there's still a lot that they're unable to do or unwilling to do, perhaps. At level 3, people are actively managing their health, developing their skills, developing their confidence, but perhaps may struggle to return to active self-management after a flare, a fluctuation, or another life event. At level 4, which is the highest PAM level, people are actively managing their condition and taking responsibility for doing so. At this level, people are also generally able to return to active self-management after a flare or a fluctuation. People can move between these levels in both directions. It's not linear, but it describes a sense of how people at certain PAM levels may present. This brings us to our second poll of the presentation. And what I'd like to know is which PAM level you would feel most confident targeting your self-management support. Again, the poll should appear on your screen so that you can take part, and we'll discuss the findings at the end. So which PAM level do you feel most confident targeting your self-management support? This could be levels 1, levels 2, the kind of early steps towards self-management. The other responses are level 3, level 4, the more confident and the more able self-managers. Don't know if you're not sure. All of them for those that are very confident in providing self-management support, or perhaps none of them. Now, for those of you in the first poll who'd said that you'd heard of the PAM before and patient activation, this may be where you've come across it, as it's become very well known in the NHS. Patient activation was discussed in the NHS Personalised Care Plan and has become a major aspect of interest there. There have also been several literature reviews that have collated evidence around patient activation, and that you'll see on the slides. I've placed some images of the titles of some of these below for those of you with interest who'd like to read a little bit more into this. There's also been a large uptake in the use of the PAM as a measure of patient activation across NHS England in particular, as around 40 clinical commissioning groups have been using the PAM and have licences to do so in specific projects. It's been trialled as a tool to stratify service provision to determine what self-management support to offer people when they come into a specialist service. And I've linked in the references here to one example of such. However, what we know from the evidence of how the PAM and the idea of patient activation has been implemented in the NHS generally is that there's still quite a lot of flexibility in how the PAM has been used as a tool. Dr. Sarah Chew and her colleagues in Leicester have discussed this and mentioned that there was quite a lot of variation in clinical styles in how people use the PAM. What we also know from case studies that have looked at how the PAM has been used as well is that it's been used in a lot of different contexts and has a lot of potential as a useful tool to determine what self-management support people require, but that it's best used with a detailed patient history that can provide context and additional information alongside the PAM scores. And Dr. Nicola Roberts and her team, where I've referenced in the last slide here, talk about this in a lot more detail. And this brings us to the gap in the research that my PhD project intended to fill, to have a better understanding of patient activation in rheumatology. What I knew from the literature when I began is that there wasn't a great deal of research into patient activation in rheumatology. And neither was there a lot of information about what patients thought about the idea of patient activation, what they thought of the PAM, and their general perceptions of what constituted patient activation. So this is where my work comes in. As part of this, I wanted to know what patient activation looked like to rheumatology patients, specifically those that are skilled and experienced self-managers at the higher levels of the PAM. So I conducted an interview study with 17 participants from 2 sites in the southwest of England. I interviewed each participant twice, around a year apart between each interview, and I analysed the findings using framework analysis. In order to be brief for the purposes of this presentation, I've provided a summary of the findings that we'll talk through now on the next slide. So what we know is that these highly activated, experienced self-managers that I spoke to in order to understand patient activation had a great deal of skill and many strategies that they were able to use. They were very proactive self-managers, very organised and very determined to take responsibility for their own health. What I found was that they were very skilled at being able to access information and help that they needed to manage their health, and were very experienced at being able to navigate the NHS effectively, particularly when managing perhaps multiple specialist teams and their GP in order to make sure that what needed to get done did get done. They had a very clear sense of what they valued in their care, including prompt access to their rheumatology team when they had questions or issues, and some preference for clinicians who knew their personal experience, because from their perspective, it was easier to engage in collaborative healthcare when they did so. They had a very clear sense of what they determined to be legitimate sources of information, and this was particularly clear when they were looking for health-related information online. They very often mentioned to me precise sources that they would go to, be it the NHS website or specific patient charities that they felt were legitimate sources of information, rather than indiscriminately searching for health-related information online. So they were very skilled at evaluating that information and applying it to their own personal needs. As well as this, they had a very clear sense of the techniques and the tools that worked best for them as individuals. This not only included self-management strategies in their toolkit, such as pacing, being able to adapt activities so that it best suited them, and perhaps physical changes to their household and their lives with adaptive equipment, but also included a sense of when they knew what extra support they needed, or perhaps what extra tools they needed to reduce the risk of a flare-up, to manage flares themselves, or to generally deal with their condition on a day-to-day basis. And this sometimes included things like hot and cold sources of pain relief, hydrotherapy, physiotherapy, and other sources of information and support. What I haven't noted on the slide, but was also of real interest, was that although I met participants with a range of experiences of health, they generally had a very positive view of their own health, and sometimes looked to other people that they knew, or people that they saw in waiting rooms, as a sense of comparison, to say, actually, there are still lots of things that I can do, and that my health means that I'm able to do. And that was used as a motivation to continue to take active responsibility for their health. As part of the process, I also wanted to know what rheumatology patients thought about the PAM as a measure, so we talked about it, and they had completed it earlier in the study. What I'd learned is that many of them thought that it was acceptable, and that the ways that they thought about patient activation were closely aligned with what was captured in the PAM itself. However, they did raise several critiques of the PAM that I felt were important to discuss in terms of its relevance with rheumatology patients. One of the items of the PAM asks about how able people are to predict or prevent issues arising with their condition. And a really important point that some of my participants raised were that although sometimes they knew when they had overdone it and they were going to burn out with their condition, they couldn't always predict a flare coming. And sometimes it was a case of being surprised by this. And therefore, it didn't always necessarily capture their experience of the fluctuations that occurred in their health. Another point was that participants were very clear to explain, although they knew the nature and the cause of their condition, and perhaps what their medications did, which were also covered in the PAM and the items of the PAM, the outcome measure didn't clarify where this information came from and if that information was accurate. Now, given that the participants I met were very clear about their confidence in being able to do so, and to be able to find the appropriate information and check its accuracy, with more than one participant even searching academic journals to find out information about their health, they felt this was a really important point to raise, to clarify. So what we learned is that although there was quite a lot of overlap in terms of how the PAM and the wider understanding of patient activation suited rheumatology, these were considerations to bear in mind if you're considering patient activation in a rheumatology context. This led me to want to understand what the skill level of patient activation was like in rheumatology more broadly. And for that, I wanted to conduct a survey study to find out what factors were associated with variance in PAM scores and PAM levels in a rheumatology population. As part of this, I recruited 251 participants from 6 sites across England and asked them to complete the PAM, along with a range of other clinical, demographic and psychosocial outcomes, to find out what contributed to variance in the PAM scores. What I learned is that the average PAM score was 58.53, which is a level 3. And as a reminder, that is being able to generally actively manage your health, but perhaps struggling to return to doing so after a flare. What was quite interesting is that this was slightly lower than average PAM scores in samples with other health conditions. And I don't know whether that's down to the population I recruited from and my sample, or perhaps a reflection of the ways that the PAM doesn't necessarily always capture the fluctuations and the aspects of the rheumatic conditions that my participants had raised in the interview studies. I asked participants to take part a second time, 9 months later as well, to compare the changes in PAM scores. And what you'll see is that there was a small but statistically significant difference in PAM scores between the 2 time points, although just 154 participants took part in the second study. So that was my full data set for the comparison. In terms of the distribution of PAM levels, you'll see from the graph on the slides that the majority of participants in my study were a PAM level 3, which lines up with the average PAM score. But actually there was quite a spread of skills and abilities across the sample. So anybody working clinically in rheumatology could expect to meet people of all PAM levels. In terms of finding out what factors contributed to variance in PAM scores and PAM levels, what I identified was that aspects of patient activation that were important to people included a close relationship with health literacy and how people particularly identified and used health-related information and how they knew what to do once they'd found this information. Health beliefs, again, how severe somebody perceived their condition to be. Health locus of control, and whether people believed that changes to their health were down to them, or perhaps chance or powerful other people, including health professionals. And self-efficacy was also important. And largely what I found were that these were also similar in terms of explaining variance in PAM levels. So they seem like really important factors for us to consider when we're supporting people and perhaps targeting interventions in clinics. And this brings us to the point of wanting to know what these findings and what the concept of patient activation means for clinical practice, and the clinical implications of this. What we know is that patient activation is a real growing concept of interest and is becoming increasingly relevant in rheumatology care. We've seen from our discussions earlier that the PAM is the best known outcome measure, although there are others, and could be a valuable tool in clinical practice to help determine what self-management support to offer people, as well as understanding perhaps the challenges that people may have in self-managing. However, there are aspects of the PAM that make it perhaps slightly less helpful for tailoring care in fluctuating conditions, particularly around managing flares and being able to respond to them when they arrive, as was discussed in the interview study. What we know is that skilled self-managers and highly activated patients really value the prompt access to their rheumatology department for their specialist knowledge about the condition that helps them to contribute to problem solving effectively, and that the personal contact with a healthcare professional who they may have met before helps them to engage in collaborative healthcare. We've learned that self-management skills such as self-efficacy, health literacy, and health locus of control, these health beliefs, seem to be really important skills and beliefs to contribute to increased patient activation, and that they're vital to manage a long-term condition, particularly a rheumatic one. So these may be targets for support in the future when working with patients. And finally, working with healthcare professionals in rheumatology to help to further understand patient activation will help to provide the skills that people need, not only to effectively assess how highly activated somebody is, but also support them in a holistic way. That means that people who are less confident and more passive, or perhaps people who are doing very well and just need a little bit of support to keep going, receive the support they need. Thank you very much for your time listening to the presentation. For now, we'll just talk through the poll results that you were completing through the talk. So the first question was, have you come across patient activation as a term before? Thankfully, we had a lovely group of you with a lot of experience in patient activation, because 75% of you had heard of the term before, and a lovely mix with 25% of you having not heard of it, so hopefully you've learned something over the course of the evening. The second poll result asked whether there was a specific PAM level that people felt most confident targeting their self-management support. And what's really interesting is that we've had different findings from this afternoon's webinar. We've found that 50% of you felt most confident supporting people at PAM level 2, so just starting to take steps to actively manage their health. 12.5% of you were most comfortable supporting level 3, so people moving towards active self-management but may struggle to return to doing so after a flare or a fluctuation. A quarter of you, 25%, weren't quite sure. And then again, 12.5% of you felt quite comfortable working with all of them. So a real mix in abilities and confidence there, which is really interesting. Now we'll start talking through some of the answers to some of the questions. The first question says, you talked about the PAM. What other measures capture patient activation? So while the PAM is the most prominent measure of patient activation, there are others out there. These include the Health Literacy Questionnaire has a subscale that captures patient activation and does it slightly differently to the PAM. And there's also the measure, I call it the PACIC, I don't know if I'm pronouncing it right actually, which talks about how closely to the chronic care model people feel like the care they've received has been, which is also used as a measure of patient activation. What lots of people also do as an alternative is that they think about proxy measures. So they ask about measures of perhaps self-efficacy or knowledge about health condition and confidence in self-management as a way of capturing perhaps an aspect of patient activation. The next question that we've had in asks, what kind of intervention should we be considering for patient activation? This, I think, is best answered in terms of thinking about skills and developing people's skills and confidence to actively manage their health. As you'll have seen from my study findings, as patient activation is closely associated with concepts such as self-efficacy, health literacy, and health beliefs, I think this may be an option for us to target patient activation interventions in order to develop people's skills so that they feel more able and feel more willing to take an active role in managing their health. The next question that comes through asks, for PAM level 1, can we distinguish between people who are unable to manage their health compared to those who are unwilling? Might these people have different outcomes? I think that's a really interesting question. And I think that actually, although when we look at individual items in the PAM, it may help us to get a sense of, perhaps the difference in groups of people who may be unable or unwilling. But I think this is a real example of where the PAM as a measure of patient activation is best used as a tool as part of a holistic assessment and in conversation with the patients and people to best understand perhaps reasons why they might not be managing their health. The next question asks, Do you think there will be a lot of differences across different diseases? For example, rheumatoid arthritis versus psoriatic arthritis. And my research in patient activation in rheumatology actually targeted people with all types of inflammatory arthritis. So there were a few different conditions in my samples from my studies. And my perceptions of that was that there would be enough shared experience between the conditions that it would help us to get a good understanding of patient activation. But actually there may be some differences between the conditions as a result of the different challenges and the different complexities that they present. And I think that that's something certainly to consider in future research. The next question asks, are PAM levels recognised in primary care? And are there any examples of shared care evidence-based outcomes? Yes, PAM levels are used in primary care, and I think that some of the best sources of information for that would certainly be in the literature reviews that I put on an earlier slide for those of you who are really keen and really interested. My expertise is largely in rheumatology and secondary care, but I know that there's a lot of knowledge and a lot of interest out there. The next question asks, did participants say how they decided what appropriate sources were? This could be important to advise other lower PAM scorers. Now, the participants in my study who looked up health-related information online were often very clear about going to specific aspects of the internet, because I know that, as the question here references, that some people are using Instagram and other forms of social media to do so. They did use social media, but actually this was generally quite rare, and most people tended to go to specific organisations, such as perhaps the NHS website or specific patient charities. And I think the example here about choosing and knowing what appropriate sources of health-related information are might be really useful to consider, particularly for those interested in group-based interventions where peers can learn from each other, because this may be a really good opportunity for those who are more skilled at identifying appropriate sources, may be able to support those who are less skilled and less activated, for them to learn from each other. The next question asks, any significant differences anticipated across the course of illness? What with it being a diagnosis of a long-term condition. Now, this is really interesting, and it was something that I looked into as part of my research. And what I had learned, particularly from the qualitative findings of my PhD, was that when I spoke to the participants, they said that it didn't necessarily mean that they learnt more and felt more able to actively manage their condition in a linear fashion. I had expected that people would become more activated and more skilled as time went on, but they explained to me that actually this was very much about the kind of experience they'd had, the severity of their health at the time, and kind of flare-ups and the kind of support that they had available to them. And this also doesn't account for the fact that perhaps people can move up and down in patient activation scores and in levels, and that it isn't a set upward linear experience. The next question asks, do you think that patient activation scores should be part of usual disease rating on an annual basis in rheumatology? I believe that understanding patient activation is really important, and making space for that in clinics and in clinical appointments is also really important. Whether people use the PAM and whether it's the best thing for each individual patient, I think is something that's quite flexible and should be down to perhaps individuals to make a decision, because while the PAM is a useful tool, it may not suit everyone, and perhaps different alternatives of understanding or discussing patient activation may be more suitable. The next question, and I'm really pleased about all your questions, thank you for sending them in, there's been a lot of interest, asks, do you think we might see this tool being used as an outcome measure with its recent popularity throughout the NHS? And I think the short answer to that is yes. It's becoming much more well-known, much more widespread. Hopefully you know more about it now than you did earlier today. And I think that, especially now you've been and you've watched this webinar on it, it'll probably come up soon and you'll go, oh, of course, I know what that is. I think that the PAM is, and the concept of patient activation is certainly growing in interest as time goes on. And the last question is, where do you think your patient activation research will take you next? What a lovely question to finish on. I think that there's an awful lot to learn about what kind of ways that we can support people at varying levels of activation and varying skills in the NHS. And what I'd like to know is a little bit more about perhaps how we support people and how we develop their skills in the future, particularly to support perhaps those who are either quite passive and perhaps unable to manage their health, as well as supporting those at the other end who are really doing quite well but may need a little bit of top-up of support, and what's most appropriate and what's most acceptable to these people.